right, Danny. Hey, listeners, welcome back to another episode of the Rick and Danny Show. Danny, I am going to save you a little bit of torture on this episode. I know you've been very, very busy these last few.
I appreciate that, Rick. I'm excited to learn more about radiation oncology and what you have to say today.
Yeah, I'll kind of just, a question I commonly get is obviously, am I a radiologist? And then we'll kind of work our way backwards from there. The bad joke I tell patients a lot of times is I have probably the two scariest titles of a doctor in my name. One, radiation, which a lot of people associate with negative things, whether that's nuclear bombs or whatnot. And then oncologist, which obviously most patients aren't super
Yeah,
thrilled to
yeah,
be coming in to seeing an oncologist. So
right,
I'm used to getting stares and certainly people not wanting to see me, which is obviously, of course, expected. But
right.
the what we do and sort of, our introduction and training is definitely, I would say, on the unique side. Most of us do a medical intern year. Some programs are different. Some do allow transitional years or surgical intern years, but I would say the majority of folks do either just a general medical year or like a transitional year. So we get a year of, at least for me at Emory, a year of, we were with the IM residents, sort of had the same schedule, same number of wards, ICUs, that type of stuff. So I like to say to people, I'm one third of you, Danny, not a full-fledged internal medicine doctor, but one out
Right.
of three. So I can fake it a little bit.
Yeah, you
And
got a
then
little bit punished your intern year.
yeah. And then after that, we go to our radiation oncology training, which is 4 years of dedicated radiation oncology training. After that, we are not radiologists. We do deal a lot with imaging. And, certainly we know how to read and interpret what I like to say is the cancer part of the scan, but certainly we are not the right people to be looking at a scan for non-cancerous reasons. But our field is very imaging based, highly reliant on imaging, to really make a lot of treatment decisions outside of certain cancers, skin cancers, some things that you can clinically see. But a lot of what we do is decisions are made and treatment is based on what scans show. We utilize everything from CTs, MRIs, PET scans, any kind of three-dimensional cross-sectional imaging we tend to use. But basically, what we do is we'll, see a patient in clinic and, we treat cancers from brain cancer all the way down to skin cancers on the toe. So literally head to toe, we're can be involved in many kinds of cancers and even in some non-cancerous things, which we could save that topic for another episode. But generally speaking, for the cancer related things, we'll see a patient in clinic and consult. Um, if they agree to do radiation, the next step is we have to do what's called a planning scan. Sometimes you'll hear it called a planning scan. Sometimes you'll hear it called a simulation scan. But basically, what we do is we get the patient in a position that, again, is dependent on what kind of cancer we're treating. So it could be as complex as a certain body mold beanbag where we actually look at gated breathing. We see respiratory movements. We see how organs and tumors move when you breathe. When we're treating things like lung cancers or certain abdominal cancers, or if we're treating something above the neck, typically we're going to make a mask, what's a radiation mask, that kind of looks like a sort of like a spider web. It's got holes in it. You could see through it. You could breathe through it, but it's sort of like a weaved mask made of plastic that conforms to somebody's face. In certain cases, and especially skin cancers, we make 3D printed boluses, which are basically these little kind of pieces of flab that help bring radiation to the surface when we're treating skin cancer. So that simulation or that mapping scan is that it's not really something I can sort of say it's always like this because it's kind of
Mhm.
very variable depending on what kind of cancer we're treating and what the clinical situation is. But the point of the scan, no matter what we're treating, is it's creating a CT scan of the patient in the position in which we plan to deliver their treatment. So it's a reproducible position for our radiation machine table, meaning when we treat with radiation, with modern technology, we can treat down to, a millimeter or so precision. So one of the most important things for us is reproducibility. How does a patient set up? Make sure they're in the right position every day. And so that's really what the planning scan is for, is to set that up. Because if you don't do it appropriately or correctly on the planning scan, you can't treat the patient effectively, so that first step is very important. Once we have that, what we do is we take that CAT scan and we combine it with all the other scans they've had, whether that's MRIs, PETs, other CAT scans. And then that's where we get in and get as some people like to say, draw our circles, where we kind of determine what are we treating, what are we not treating, that type of what we call target delineation. And once that target delineation is done, then it goes to radiation planning. So then that's where we take those drawings or contours on the CT scan and actually run nowadays Monte Carlo simulations, where we basically are trying to figure out what is the best beam angles, what is the best arrangement of radiation to try to get the radiation where we want it and try to keep it away from where we don't want it. And that part of the process is definitely multidisciplinary. So we're involved with dosimetrists, which go to school specifically for this purpose, to help us and for planning, as well as medical physics are also involved both in the planning as well as in the QA aspect of planning. So it really is a team effort, and radiation oncology in general is a big team effort. Certainly not all driven by the doctor. So that planning process, depending on the case, depending on the complexity, can be as short as a day or two to as long as a week and a half. And then once the radiation plan is created, the physicists, the medical physics will run QA. So what that basically means is they'll take it's a easiest way to think about it is like a tub of water, and they'll actually put it on the radiation table and run the plan as if that tub of water was the patient, to make sure that what we plan for is actually what's being delivered out of the machine. So it's just another safety check, basically. Once that QA part is done, then the patient's treatments will start. The other question we commonly get is, well, how many radiation treatments do I need? And unfortunately, that is also an extremely variable question. It could be as short as just one treatment to as long as 45 treatments. It's kind of the range in which, across all different cancers and non-cancers we treat. So it's a pretty loaded question there. But so essentially, as short as one, as many as 8-9 weeks of treatment in some cases for certain cancers. But the treatment itself, the way it works is a patient will come in. They'll typically change into a gown or a robe. And then the radiation therapists, these are folks that go to school just for this, training. They get the patient on the table. They set them up in that exact mold we made for them at the mapping scan. So whether that's the mold, whether it's a mask, whether it's, whatever, they're going to be set up in that position. And then here at CSNF, all of our machines are equipped with imaging on the machine itself. So we'll take a scan of the patient. It's basically a CT scan to make sure that every single day they get their treatment, their organs are lined up where they're supposed to be, the patient's in the right position, the target's where it's supposed to be. So it's just even another redundancy, another safety check to make sure that, what we plan for and what we intend to do is actually being delivered. And so that happens every day. And then the patient will go through their radiation course, as they'll be seeing their doctors during that time at least once a week when they're under treatment. And then they finish, and then we follow them up depending on the cancer, typically with scans or clinical exams or blood work, depending on what the situation is. So yeah, that's kind of the quick run through on sort of the process from patient comes in to see me in the office to finishing their treatment.
Right. No, great overview, Rick. I think the most common questions I get, in the medical oncology world, if we're sharing a patient, either giving them chemotherapy with radiation, or maybe the patient's just getting radiation treatment without any, medical oncology treatment, is, how long is the radiation treatment? One is how long is it when I'm there for an individual treatment, and how long is the radiation course going to be total? And how is that broken up? And I kind of like give them my rudimentary kind of explanation of like, you're trying to reach a target dose for a particular type of cancer, and then you break up that dose into different fractions or days, and it's different for different cancers, and maybe depending, like you said, on the technique of radiation too. Um, what I guess I had a question when you were describing the safety checks. How has that changed a lot in the last like 10 years since when you were in fellowship and or in residency and came out? Like, are there more safety checks? Is it just more sophisticated software and imaging, and how has that changed to make it safer for patients?
Yeah, I mean, short answer is yes. It's kind of a combination of all that. When I was in training, we did have the onboard imaging. Certain machines and certain manufacturers have better products than the other when it comes to, some of these different aspects. But the general principle of onboard imaging has been around for a long time, at least, I would say 15 plus years. The what's really changed though is, in the last probably 8 to 10 years has been the adaptation of CT based onboard imaging. So before, we would be able to only really get KV images, so like X-rays. So you could really only see kind of bones and, maybe some soft tissue, but certainly you couldn't see organs or anything really like that. So we knew we were lining up to bone, or we knew we were lining up in the general area. But what the cone beams on CT have allowed us to really do is, when you're talking about, easiest way to think about it is like a prostate. The prostate sits between your bladder and your rectum. We want to keep the bladder as full as possible. We want the rectum to be as empty as possible. So by having these onboard cone beams, we can see every day to make sure that their bladder is kind of in the range we want it to be, and the rectum's in the range we want it to be, in addition to making sure, obviously, the prostate's where it's supposed to be, that type of thing. So it allows for some more soft tissue delineation, which I think helps in terms of just confidence in knowing we're treating what we want to treat. And, there is some data out there that onboard imaging like this does reduce side effects of treatment. It also allows us to push the envelope. And that's really where a lot of the newer, stuff with radiations coming out is sort of treating things we couldn't treat before, either because we couldn't get a high enough dose there safely, it was those type of things. So that's where some of this technologies come into play. There is now kind of a field of what they call adaptive radiation, where you're actually, changing the plan on the fly day to day at the machine. There's some data that's coming out with that. There's a lot of caveats with that. There's some trials that have been published with, I would say, questionable methods to compare the two, but that could be, I think, something that could be coming in the future is if there's really good data, and a good system for sort of daily adaptations where you actually would adjust the plan based on how someone's setting up that day, is an area. And then there's also now, not as new, but been around for certainly several years, of MRI based radiation. So, or what they call an MRI LINAC, where instead of a CT, it's an MRI that's done. That's certainly something that could be coming into play for some, a very narrow range of cancers, thinking like upper abdomen, pancreas, things like that could be potentially beneficial, I think would be a good use case. But so far with that stuff, it's sort of, I would say still, I would say in the pipeline of generating data to make sure it's justified, because obviously with any of our technologies, the fancier you get, the newer you get, there's a, very high cost burden to implementing that. And certainly, you don't want to put a patient out for some very expensive treatment if there's really no benefit to doing it.
Yeah, that's fair. I think two more questions for you, Rick. One is, after you see a patient for new consultation for radiation treatment to whatever organ and disease they have, how long do you expect before getting them started on treatment? And what is that variability depending on their disease?
Yeah, so I think for like if there's like a patient with like a painful bone metastasis and in a lot of pain and we want to get started quickly, turnaround time, should be no more than a day or two, 3 days at the most type thing for a standard situation where you're trying to get somebody, started as quickly as possible. For complex treatments, head and neck cancers, things that are going to require a little more time, both for target delineation as well as planning, those can take, week and a half, 2 weeks at the most. But nothing really should go, barring some, you're waiting on some other diagnostic scan or something like that, but nothing should really extend beyond a few weeks at the absolute maximum. But, I would say average is probably around a week or so, week and a half, for kind of your standard, non-urgent or emergent case. Because the other thing is too, we don't want to push our staff too hard. Our physics and dosimetry are very busy. They're doing quite a bit, not just planning, but like I mentioned, there's QAing and there's other things that need to be done. So it's trying to find that balance, like I know you guys do with your chemo nurses, of not overloading them on any one particular day with too many patients type thing. So, but yeah, I think it's very situational dependent, but that's kind of the rough basic range. And then I think you had asked the question earlier about, how long do you tell patients to be on treatment? Yeah, unfortunately, a lot of times it can be variable, as you said, but the reason it's variable is some cancers don't require a lot of radiation. So like lymphomas is an example where we have backed way down on the dose from what we used to do historically, decades ago, and the field size has gotten so much smaller than what we used to treat. So, with lymphomas now, when I see patients, those are sometimes, good consults, because I get to tell them they're really not going to have a ton of side effects because the dose is so much lower. Versus other cancers like prostate cancer and head and neck cancers and, some things like that, lung cancers, they require more of a dose to try to give maximum efficiency or effectiveness at killing the cancer. But obviously the trade-off is the potential for more side effects depending on, where we're treating. But it's really, it's all comes from biological principles and from clinical trials. So, there's the principles of fractionation, and why we fractionate is really to try to get that biological dose we need to the tumor. But by fractionating it, it lowers the risk of normal tissue damage. So it lowers the risk of more so focusing on long-term side effects. So the reason we fractionate is really to get the biological dose in we need to the tumor, but minimize the risk as much as we can of long-term side effects. And then different scenarios obviously can determine different fractionations. For SBRT, which is stereotactic body radiotherapy, or radiosurgery, where we're treating brain metastasis with targeted treatment, that's a very different way to approach it. That's where we give very high doses over a fewer number of treatments. The mechanism of action is also very different. So when we do that, the goal is really to ablate the tumor. It's really the radiation itself, the ionizing radiation it's more of an ablative goal over a fewer number of fractions. In fractionated or kind of traditional radiation, it does its damage by more of a DNA damage. So it's less that the radiation itself is killing the cancer. And what happens is the radiation damages the DNA within those cancer cells, so that when those cancer cells go to divide, they don't have the right DNA to do it, and so they die. So it's more of a drawn out death as opposed to kind of a more ablative death with SBRT or radiosurgery.
Yeah, that makes sense. That's a good explanation. Well, thanks, Rick, at having this great discussion about your field, radiation oncology. And
it was awesome. It was fun to contribute for once. It had been a few episodes where, I didn't really understand what these words meant, bispecifics, anemia. I still can't even spell anemia, I don't think. So I appreciate you letting me talk for once, Danny. It's very nice of you.
It's my pleasure.
Thank you for tuning in to another episode of the Rick and Danny Show, and we will be back.
Until next time. See you later.